Glossopharyngeal neuralgia is a rare but debilitating craniofacial pain disorder caused by irritation of the glossopharyngeal nerve. The condition presents as sudden, severe, stabbing pain localized to the ear, base of the tongue, tonsillar fossa, and beneath the angle of the jaw. It is triggered by common activities such as swallowing, chewing, coughing, or even talking. Unlike trigeminal neuralgia, which affects the face, glossopharyngeal neuralgia involves the oropharynx and auditory canal. However, due to its rarity, an incidence of only 0.2 to 0.7 per 100,000 people per year, it is frequently misdiagnosed. The most common cause of glossopharyngeal neuralgia is vascular compression of the glossopharyngeal nerve at the root entry zone in the medulla. The primary offending vessel is typically the posterior inferior cerebellar artery, or, less commonly, the vertebral artery. Compression leads to demyelination and hyperexcitable nerve fibers, resulting in paroxysmal pain episodes. Secondary causes include tumors of the cerebellopontine angle, such as vestibular schwannomas or meningiomas, parapharyngeal space lesions and pharyngeal malignancies, multiple sclerosis affecting the brainstem, and Eagle syndrome, where an elongated styloid process irritates the nerve. A thorough history and clinical examination are crucial. Patients often describe pain that is unilateral, paroxysmal, lasting seconds to minutes, and triggered by swallowing, yawning, or speaking. A clinical test called the glossopharyngeal nerve block can help confirm the diagnosis. Injecting a local anesthetic near the tonsillar fossa can temporarily relieve symptoms, differentiating it from trigeminal neuralgia or Eagle syndrome. For imaging, the gold standard is MRI with high-resolution 3D Fiesta sequences, which can identify vascular compression of the nerve, tumors compressing the glossopharyngeal nerve, and demyelinating lesions in cases of multiple sclerosis. If Eagle syndrome is suspected, CT imaging can confirm an elongated styloid process. Most patients initially respond to anticonvulsants, which stabilize hyperexcitable nerve fibers. Carbamazepine, 200 to 600 mg/day, is the first-line treatment and can provide substantial pain relief. Oxcarbazepine is an alternative with fewer side effects. Gabapentin and pregabalin can be considered in refractory cases. However, medication side effects such as drowsiness, dizziness, and liver toxicity limit long-term use. Up to one-third of patients fail medical therapy, necessitating surgical intervention. For patients with persistent or severe symptoms, microvascular decompression, MVD, is the most effective surgical treatment. A retrosigmoid craniotomy is performed to expose the root entry zone of the glossopharyngeal nerve. The compressing vessel, most commonly PICA, is gently separated from the nerve using Teflon padding. This relieves mechanical irritation and prevents further demyelination. Outcomes show that 64 to 75% of patients experience complete pain relief postoperatively, and an additional 16 to 25% have significant improvement in symptoms. The primary risk includes vagal nerve injury, which can lead to hoarseness or dysphagia. Other surgical options include rhizotomy, which involves selective sectioning of the glossopharyngeal nerve for non-compressional cases, and radiofrequency ablation, used for patients who cannot tolerate major surgery. Glossopharyngeal neuralgia remains a challenging, yet treatable condition. Early recognition and differentiation from trigeminal neuralgia and Eagle syndrome are critical to prevent misdiagnosis. While carbamazepine remains the first-line therapy, microvascular decompression is the most definitive treatment, offering high success rates with minimal recurrence. For ENT and skull-based surgeons, a multidisciplinary approach involving neurologists, radiologists, and neurosurgeons is essential for optimizing patient outcomes.